Hello, my name is Aiden, and this is my final project on United Health Group. I wanted to go ahead and start off the slideshow by talking about LHC Group, which is a national at-home health network. They got acquired by United Health, and that's what I did my last slideshow on, talking about the strategy behind United Healthcare buying them. I did come to a Vero analysis, or a Vero verdict, and that was that by acquiring LHC Group, United Healthcare gained a competitive advantage, but it's not a permanently sustainable one because competitors can build or contract alternatives. So I want to talk about the corporate strategy of whenever United Health bought LHC Group. So I said that they wanted to combine House Calls, Optum, and LHC Group together to improve the outcomes of patients as well as lower total medical costs by combining the data, skills, and resources together. Okay, so I found that there was an external threat within LHC Group and United Healthcare. So in 2023, Medicare Advantage payments were sent out in the amount of $3.7 billion to assessment-only diagnosis. So what this means is that there were $3.7 billion of payments that went to United Healthcare that were only tied to the diagnosis, and there was not follow-up care. So what this means is that United Healthcare would go to your house with LHC Group, they would have these diagnoses of it, and then the care was not properly followed up on, or that they were inaccurate in the diagnosis that they had to United Healthcare, right? So that was found by the Office of the Inspector General, and that's a gap in the care between United and the house call and LHC Group system. So overall, whenever we back that up on the strategic verdict of United Healthcare, I said that they have a strong but underutilized competitive advantage. Because it's strong because the combination of their insurance, patient data, care coordination, and out-home delivery is valuable, but this incomplete follow-up after house call assessments leaves patient value and medical savings uncaptured. So whenever they come to your home and they do not have these diagnoses that are sent out, whenever they don't do that properly, it's going to leave patient value and the medical savings uncaptured by United Healthcare. The implication is the advantage is only sustainable if United Health integrates these capabilities and proves better outcomes with LHC that lower total costs. Okay? So the evidence of this follow-up gap, I want to talk about that more. So the current handoff. House Calls, which is under LHC Group, sends findings to the primary care physician and asks the patient to discuss them at a future visit. There's a delay in time. United Healthcare says the primary care physician report takes an average of 4 weeks to arrive. So they'll do the diagnosis, send out a report to the PCP or the primary care physician, and then that takes an average of 4 weeks to arrive. A referral report does not prove treatment occurred. So just because I sent out this report, it doesn't mean that we necessarily already solved the problem or did solve the problem that happened. So we have this report, we send it out, and we hope for the best is essentially what they're doing. United Health should remain accountable until all of these high-risk follow-up care is completed. So I believe that United Healthcare, they should take initiative to make sure that these referrals turn into care that needs to be happening. So there's a follow-up gap here. So what I am recommending is that we create a closed-loop care pathway for the highest risk Medicare Advantage members. What that would mean is that I'm going to identify the problem that I need, so I have a diagnosis. I'm going to assign a coordinator to them, and then I'm going to have that coordinator be in charge of scheduling, treating, and measuring all of the care and follow-up that we do. So instead of us sending out this package or referral to a primary care physician, we're going to just assign a coordinator and then have them follow up and schedule and do all that kind of stuff. What this does is it creates accountability for United Healthcare to finish out these diagnoses and give care to the people that need it. The case would remain open until treatment is declined, or is ruled unnecessary. So there would be a navigator with you on this case the entire time. And that is my recommendation. The effects on this, on the value stick, are multiple. First of all, it would increase the willingness to pay, because faster follow-up and preventative treatment can improve outcomes, reliability, and retention between people that are already in your health system. United Healthcare does have increased costs under this measure in the form of navigators and home treatment that will add upfront costs to the network. But in response, there would be avoided ER visits and hospital stays that could create savings. So, supplier willingness to sell would not be affected significantly, but the value captured could be enormous for United Healthcare because of that avoiding hospital staying and the medical savings by not having the person go to the primary care doctor for everything, right? So, what I also recommend would be that they create a pilot to measure success under this program. So what I propose is that you would have 10,000 high-risk Medicare Advantage members in 5 markets where we already have a strong house calls and LHC group capacity. What I would do is I would assign an Optum coordinator after serious findings to track each member for 12 months. I would compare the outcomes with similar members receiving care under the current model, which is the PCP sending out the referral, and then I would have some proposed targets that I would want that to hit. And after 12 months, you would be able to have a decision on to expand it if the medical cost savings exceeded the program costs. So this is a pilot to understand how is this program doing in terms of patient outcomes and costs. There are some risks and assumptions under this. So one key assumption is that coordinators improve completed follow-up and outcomes, as well as earlier home treatment prevents hospital stays enough to lower total costs. The main risks are staffing shortages within LHC group. That has been a problem for a significant amount of time, and also that home care may cost more than hospital spending if the program is unsuccessful. The stop condition would be to stop or redesign if avoided medical spending does not exceed program costs after 12 months. All right, and that gets me to my references. And AI use. I did use AI to edit and organize the slideshow. I also used it to help me find sources that I could use on this project and all that kind of good stuff. Thank you.